She's doing that, just as a reminder, the topic tonight is how to deal with lack of insight, and the format we're going to use. If you can go back, Molly, to back one slide. We're going to use the same format. Thank you. That's perfect. The same format we did last time, which is approximately half of the program will be presentation by Dr. Turkington. You were provided with the slides yesterday in the same email that had the Zoom link, and there will be times during that where questions will be taken, but just a few. And we ask that those questions relate to the topic that Dr. Turkington has been talking about, as opposed to more general questions. The second half of the program will be a question and answer, where you'll have plenty of opportunity to ask whatever questions you wish of Dr. Turkington, and Bob Reiser will also probably participate in some of that discussion. The first part is going to be videotaped, and we will post it on our website in slightly edited fashion. So be mindful of confidentiality issues if you do ask questions in the beginning. The second part, we will record for our purposes, but we will not put it on our website. I will say that we are very fortunate. The first session was videotaped, and Molly told us this morning that it is now up on our website, so you can take a look at it if you missed it or want to revisit it in any way. Now that we have the bugs out of the system of posting these videos, we'll make sure that the video for this session is posted before the next one. So for people who do miss, you can stay up to speed. In terms of the question format, as I said, try to keep your questions general without too much personal information for confidentiality reasons. And also, we simply can't ask Dr. Turkington to provide individualized advice from England all the way to California. So keep your questions as general as you can. We've already talked, the screen is now up, we've talked about confidentiality. Zoom etiquette, very simple, just keep your microphone muted. As I said, if you have any logistical questions, don't hesitate to reach out to Molly, who you've seen on your screen. I'd like to introduce her. She's just been terrific stepping in here and helping us with it. So you can reach out to her through the chat or her email, as I said. In terms of the questions, what we're going to do is what we did last time, because from our standpoint as presenters, we think it worked pretty well. I hope you did too, which is post your questions in the chat to Dr. Reiser. He will then take those questions and essentially curate them, weed out duplicates, and try to put them in a format that will be user-friendly for everybody. So go ahead and send him your questions. He will use that information both in the breakout during the presentation with the 2 or 3 questions at various points along the way, and then for the second half, he will be curating those as well. And also, one of the feedback items we got was that people really enjoyed some of the give and take between Dr. Turkington and Dr. Reiser in response to questions, and so we intend to incorporate a little bit more of that in the second half. The final guideline is the survey. I come full circle to the survey. I cannot overstate how helpful your responses were. So please, if you still have comments and haven't commented on session 1, you can still do that. But most importantly, session 2, because these really do build on themselves, and we will incorporate your comments and questions as best we can for the next session. As the screen indicates, you can either access the survey in the chat, or in the email that Molly circulated yesterday late in the day or early evening that has your Zoom link in it. It also has a link to the survey, so you can access it either way. And if for any reason you have trouble, just reach out to Molly and she'll walk you through it, because that information is absolutely invaluable. So with that background, I turn it over to Dr. Turkington.
Okay, thanks very much. So, yeah, sorry for those gremlins at the start there. I crashed twice, but we now have some technical assistance, so we should be all right from this point on. So, this webinar today is building on principles of recovery, which we did last time, to go right to the very heart of psychosis. The core symptom is lack of insight. And what we want to work on today is to work out what is insight and why does it go, and what can families do to help insight to recover. Next slide, please, Molly. Now, one important thing to consider is that when people refuse our help, it's very often a complex matter. So loss of insight may well be a part of it, or it might even be all of it, but more often there are numerous factors involved. Things like stigma, failure of adjustment, interpersonal problems, shame, cultural aspects. There's normally lots of different reasons why somebody might be refusing to accept help. But loss of insight is almost always a bit of it. Next one, please, Molly. So today we're going to be working on thinking about what is loss of insight, and also considering the parallel subject of anosognosia. Now, I think understanding about these two terms is quite important. We're then going to talk about medication and the relation of medicine to insight recovery, and then how the psychological treatments work to help insight recover. That is cognitive behavioral therapy, psychoeducation, and of course, family therapy. And we'll end up with trying to pull this all together. And as in the last presentation, we're going to talk about what happens when people not only recover insight, but they move beyond the rest of us into a state of enhanced insight, which is something that I've seen many times in people who recover from psychosis. We're also going to have a video illustration of loss of insight and consider how we might best talk to the client that is presented. Next slide, please, Molly. So we're going to start with me role-playing one of my clients who I saw more than 50 times, and he had a fixed religious delusion that he was the second coming of John the Baptist. Now, he believed that it was his role in life, it was his mission to pave the way for the coming of Christ, which was going to be in the Newcastle area in the north of England, by destroying all the pornography in his local area. And he set about going into shops, taking off any magazines that he thought were pornographic, taking them outside and setting them on fire. So we're going to see an early interview with this man who believes he's John the Baptist. I am role-playing my patient. The case is disguised, so nobody will actually be able to know who this is, but it's a real illustration of the difficulties in working with someone with a delusion when there is no insight present. Can you put on the video, please, Molly?
So we were talking about your idea that you're John the Baptist, is that right?
No, it's not an idea that I'm John the Baptist. I am the second coming of the Baptist.
Okay, you sound very, very convinced of it.
Well, there's absolutely no question about that.
Okay, what makes you think that's the case?
Well, at the time that Christ first appeared, John the Baptist went before him to make his way straight. Now, the second coming of Christ will be in the northeast of England, and that is why I'm here. It's very obvious. I look like John the Baptist. I've got the same kind of facial hair. I've got all the same zeal and prophecy.
So what makes you think that the second coming will be in the northeast?
Well, I actually saw a revelation of a cross in the Wall's End area while I was down there. And I came to understand that this was my mission, to make the way straight. And the other thing that became apparent to me was that I had to destroy all the pornography in the Wall's End area. So I entered some newsagents, took all the pornography off the shelves, set a lot on fire, burnt them.
What happened?
They phoned the police.
Yeah.
And the newsagent was angry. I said to him, you don't understand what this means. This is the start of the second coming.
So you've started your plan to rid Wall's End of pornography, and it's starting to get you into trouble.
It is getting into trouble, but there are people in Wall's End that are strongly backing me.
Yeah. Who's that?
There are people in the local church who have said to me, by the way, I agree with what you've done.
Okay.
Pornography is a terrible thing.
Okay. So some people have agreed with you.
Oh, yeah.
I'm wondering if we could think about perhaps another way of seeing it. I'm wondering if anyone disagrees with you, anyone's come and
yes,
told you.
People do. But it was the same for John the Baptist first time round. There were people shunned him and disagreed with him, and he was utterly determined to complete his mission.
So the fact that some people have perhaps behaved like this to you doesn't discourage you in any way?
Not in the least. Are you trying to argue to me there should be pornography in Wall's End?
No, I guess what I'm saying is...
Not as much.
Yeah, I can see that you feel that way, but no, I assure you, that's not where I'm coming from. I'm just wondering if you've come up against people who have had that point of view, and it sounds like you have, and it hasn't discouraged you at all.
Well, it's very simple. They are pornographers, and it must be destroyed.
Okay. Putting that aside, I'm wondering if you can see any other explanations other than you being John the Baptist for what's going on here.
Absolutely not.
Has anyone ever said to you that, don't be so stupid, you're not John the Baptist, or try to convince you you're not John the Baptist, family members or friends?
They've tried to say that.
Yeah. What have they said to you when they've said
to you, oh, you went to the local primary school. How can you be John the Baptist?
Right.
But the same things were said in days of old.
Meaning
that Christ is going to reappear in Wall's End, and it's my mission to make the way straight.
Yeah.
It doesn't matter what school I went to.
And they're saying to you, look, how can you be John the Baptist? I've known you all my life, and we grew up together, and you weren't John the Baptist then.
That's what they were trying to say.
Yeah. What do you make of that?
Absolutely ridiculous. The only difference is the name. That's the only difference.
Yeah. Okay. And is there anything else that they've tried to say to convince you that you're not John the Baptist?
Well, they gave me a fine, and they put me in prison for a brief period.
Yeah.
And I said, that isn't a problem. A prophet usually ends up in prison.
Yeah. Okay. So we've just talked, I guess, for a few minutes about this idea that you're John the Baptist. And I know that you've said it's not an idea, you actually are.
Yeah. And you seem very supportive of my mission.
Well, I guess I'm not sure I'd go as far as that. I guess I would say I'm not sure what I think yet. And perhaps one of our tasks could be to find out a bit more information about it together during our sessions together. I wonder if you have any doubt at all in your mind about whether you're John the Baptist.
I have absolutely no doubt. And this is something I've told you before.
It is, yeah. I know that you have said it before. I'm wondering if you gave it a rating out of 100%, how much you believe that you're John the Baptist?
100%.
Absolutely.
No doubt whatsoever.
Okay. And would anything change your mind at all about that?
How can anything change your birthright and your mission and your prophecy?
Yeah. You seem very certain about it.
I'm getting more certain all the time.
Yeah, okay. What's it like me talking to you, questioning you like this about it?
I am getting increasingly sure that my mission must be completed.
Okay. Well, maybe we could leave it there for today and think about another way to tackle it next time. How would that be?
Well, I don't want to tackle anything. What I want to give you is information about what's going to happen in Wallsend so that you can read about it. And I want you to join my anti-pornography team. We're going to be visiting newsagents all over the Wallsend area.
Well, that doesn't sound like a usual goal of therapy. One of the things we could...
I'm not bothered about therapy.
No. Okay.
I'm talking about a mission to change the world.
Okay. Well, maybe we could think about if we can find a way forward together next time. It sounds like we've got very different agendas about where we want to go in terms of taking this forward.
What's your view on pornography?
Well, I'm not sure. Sorry, can we cut?
So that was a fairly typical, really, of a man with a grandiose religious delusion, no insight at all, and worryingly, he was acting on his delusion. So he was actually saying and doing some quite dangerous things there. So as a family member of somebody like this man, the first thing to consider is, what is the risk that's going on? And is there anything we could do to help reduce the risk? So first of all, he said, they are pornographers and must be destroyed. Now that sounds a bit threatening. That's a worrying statement. So I'll be wanting to ask him what he meant by that, and if he was actually thinking about hurting anybody. That would seem a very important question. And the next sort of question would be, can we stop him from burning things? Setting fires is just not allowed. It's extremely dangerous, and he will end up in prison for a long time. Now, people like this do extremely badly in prison because their beliefs are confronted by the other prisoners, and there's usually no treatment in many of the prisons. So they just tend to deteriorate in prison. So what could we do to stop them setting fires? Well, there's a number of possibilities. So I actually suggested to him, I said, there's a bit in the paper about you for setting these fires. Why don't you write something and I'll try and get my friend at the newspaper to publish it for you. So then instead of burning stuff, you could have a little piece in the paper. But I'm only doing that if you will agree to stop setting fires. Now, he did agree to this plan of having a little bit in the paper. And what he wrote in the paper was actually quite good. And towards the end of it, he came on to his bit about Christ coming back to the earth and it going to be in the Newcastle area, which people thought was all really quite interesting. And it stopped him setting fires for a week. So we needed to do something to stop him setting fires, reduce the risk, and then we can try and do something about his insight. Now, we're going to see another video of this man later when we do a bit better with improving his insight. Can we have the next slide, please, Molly? So, what is the definition of insight then? Well, it's summed up by the top one there. awareness of one's own self and one's own mental state. So I pretty much know that I'm Douglas, and I've always kind of been me. I have that knowledge of me, and I kind of know what my moods do and how I feel emotionally. And it's that continuity of understanding of yourself, which is at the heart of being insightful about yourself. When you become psychotic, you lose your sense of self and you lose your boundaries. So if I was to get a psychosis, I would no longer be sure that I was Douglas, and I wouldn't be sure what my thoughts and emotions were doing, and I wouldn't be sure if they were mine even. That is at the heart of what this type of severe mental illness is all about. So there's 3 elements of insight as described in Aaron Beck's insight scale, which measures insight. First of all, the belief that voices and delusions are about the person and they aren't real external phenomena. So if you realize the voices are about you and that those delusions aren't actually people outside, they're your own beliefs, you've got insight. If you understand that these symptoms are part of a mental disorder, then that's the second component of insight. And if you accept that treatment is needed for that mental disorder, that's the third component. Now, the thing about these components of insight is that they're not always the same. So we can get someone who believes their voices and delusions are all real and outside them in the world, but who do believe that they should take treatment. So the 3 parameters of insight are worth measuring because they're different. Now, I said that loss of insight was the core symptom because it is present in everybody who gets a first episode of psychosis. 100% of people lose their sense of self and they lose insight. The next commonest is hallucinations. That is, your thoughts appear distorted and external as real external voices. Your beliefs become delusional, just like the man who believed that he was John the Baptist. And that's present in 50% of people. And some people stop making sense. Their thoughts become jumbled. So they're not able to communicate easily. Now, they have found the bit of the brain that seems to be responsible for this core symptom of psychosis. Now, we spoke about the insula last time out as this small bit of the brain, and its job was to decide what is inside your body and what is outside. Are these voices or are they thoughts? The insula is deciding that. And that bit of the brain, the insula, seems to be where insight is located and where our sense of self is located. And it seems to be the right side of the brain this is located in. So there's a little bit of my brain, when I say I am Douglas, there's a bit of my brain that is resonating with that. And apparently, we all have this. So that's kind of what we know about insight and loss of insight. So let's do the next slide, Molly. So what is anosognosia? Now, this is a neurological word, and it was described way back in 1914. And it was about a person with a disability who had no self-awareness of it. And it was described in terms of people who had developed a left-sided stroke. So they have weakness or paralysis of the left arm or left leg. And they don't know that their left arm or leg are weak or paralyzed. They will tell other people they're just having a rest. That actually works fine. So it's that lack of awareness of a disability. And it's based on stroke and tumor when that bit of the brain is actually being pressed upon or destroyed. So insight is lost when the insula overheats and becomes too active in psychosis. And nosognosia occurs when the insula is destroyed by tumor or stroke, and it's actually harder for that to recover. So the bottom line here is we should be hopeful about loss of insight. It's caused by a malfunction of the brain, and we should be able to do something about that. Whereas anosognosia is normally caused by damage to the brain, and it is more long-lasting. Next slide, please. So perhaps these things lie in a spectrum. If you think about left-sided weakness, that is caused by the right side of the brain. We have the fMRI studies showing the right posterior insula as the location where insight and sense of self are in the brain. So we're quite near here to actually working out that anosognosia and this loss of insight are related to the function of a right-sided bit of the brain. But that bit of the brain isn't damaged in psychosis, so perhaps we can be optimistic because the thinking bit of the brain is the front, and the thinking bit of the brain is where the therapies work. So when we decide to do a relaxation exercise, that's frontal, and it's doing the relaxation to relax the body and maybe to start to relax those bits of the brain that are overactive. So the feed is from frontal to temporal, and that's a bit of the brain that's overactive. So the therapies can calm the brain and allow insight and sense of self to start to come back. Interestingly, the antipsychotics drugs act directly on the insula and that part of the temporal lobe. So they're trying to calm it down by blocking the receptors there. And we're working with therapy to try and calm it down from the frontal side. So both medicines and therapies together are acting to help insight and sense of self recover. We should be optimistic that this is going to improve. Next slide, please, Molly. Now, stigma has to be mentioned because service users, people with psychosis and bipolar and schizoaffective, they tell us that the stigma is actually worse than the symptoms. So very often the reason that they don't take medicine or don't attend for therapies or visit the psychiatrist is because they are so stigmatized by the label of schizoaffective or schizophrenia. I mean, if we tried to tell John the Baptist there that he had paranoid schizophrenia, that is not going to go down well, is it? He's going to have a seriously negative reaction to that. This is a patient I had called Charlotte. She had been given a diagnosis of paranoid schizophrenia, and she felt so stigmatized, she refused to take any medication because there was a little leaflet in the medication box which said, these tablets are for schizophrenia, and she was not having that. She became very isolated. She wouldn't talk to anybody. She wouldn't go to the day hospital. She was deteriorating very badly. I went out to see her at home and I said, is there anything we can do to engage you in treatment? And she said, well, I want that diagnosis out of my notes. I don't have paranoid schizophrenia. I've told you before, I've had a number of traumas in my life, and I hear the voice of the person who abused me. I don't have schizophrenia, and I want you to change that diagnosis in my notes to complex PTSD. So that was an interesting challenge. I went and looked at her case again and reviewed it. In actual fact, she sat on the borderline between the complex PTSD group of diagnoses and the schizophrenia spectrum. So I was quite happy to switch from the DSM to the ICD. And I said to her, I think you're right, actually. I think complex PTSD much better describes what you're suffering from. So I'm going to change that in your notes. I'm going to tell your GP, what do you think now about taking some medicine and having some therapy, working up to the treatment of your underlying traumas? She was delighted. She was proud to have complex PTSD. I heard her outside telling people in the day hospital one day, I've got PTSD. The doc's got it at last. I've not got schizophrenia. She engaged in therapy. She started taking medication. She made a wonderful recovery and is now a very strong advocate for the diagnosis of complex PTSD, which is appropriate to about half of the people with a schizophrenia diagnosis. Next slide, please, Molly. Now, the other thing about insight is meant to be fixed. You know, so you've lost your insight, it's meant to stay the same from day to day. Or if you've got a delusion, the amount of insight that you might have in the delusion isn't meant to fluctuate. The great psychiatrist Carol Jaspers said, a delusion is a fixed false belief without insight. So we measured this on an insight scale on 4 people with really severe delusions. We didn't give them any different treatment. We just measured their delusion and their insight. And what you can see by the different charts here, this is over 3 months of weekly ratings, is that insight varies dramatically. I think this is very good news for families. Because what this means, if you look at the top scale of the blue one, at week 4, 100%, he has no insight at all. So as a family member, speaking to that man at that point, you're not going to get very far. But the week before, week 3, there was a real opportunity. He had a bit of insight there. So families want to just keep checking in with their loved one that doesn't have insight and keep asking curious questions. And as the insight fluctuates, you will get a chance to find out more about the delusion. And it is in that arena that insight can make a durable recovery. If you look at the second bottom one, the orange line, there's almost a recovery in insight, but it bounces back up again. So people with psychosis and delusions, their insight fluctuates. It depends what is happening in their social environment. It depends the people they're speaking to, and you can get quite big changes. I think this is massively encouraging for families. Next slide, please. So, should we be optimistic? Well, if you measure insight, 3 years after the first episode, the majority of clients have recovered insight. The natural tendency for loss of insight is to recover. 55% realized that voices and delusions were their symptoms. One lady said to me when her voices were bad one day, I knew it was just my schizophrenia playing up. I didn't get too upset about it. I knew what it was. 64% understand they have a mental disorder that has got a cause and needs treatment. And 67% understand that treatment is needed. Now, not all of them agreed that medicines were needed. People are very variable in whether they think medicine is the way to go or whether it should be therapy or some holistic complementary type approach. So people thinking that treatment was needed doesn't mean they're going to take antipsychotic medication. Next one, please. So in the situation where the brain is overheating, the temporal lobes are overactive, how would that happen? Well, the brain overreacts like that if you've got a genetic predisposition and you're really stressed, if you're not sleeping very much, if you're traumatized, or if you're using amphetamine or strong cannabis. Those type of drugs will all make that bit of the brain fire up. And when there's too much dopamine in that bit of the brain, you start to get it wrong. You start to take too much meaning from the environment. So the fact that your neighbor has put up a security camera, if your dopamine levels are up, means they're watching you. And not only that, they're probably part of the mafia or some other organized crime syndicate, and you are under threat. All they've done is put up a security camera. But if your dopamine is up, you get it wrong. Now, what this guy Kapoor said was the medication will switch the dopamine down again, and these symptoms of paranoia will submerge into the subconscious. But if the medicine is stopped, they will simply re-emerge. So what Kapoor argued was that you pretty much always need to do something with the symptom. You need to work on these delusions, question them, look for evidence. And when you do that, you can process the delusion. And this is what is normally done in cognitive behavioral therapy. So the argument was, we want the medicine, it's going to let insight recover and submerge the symptoms, but we've got to do the therapy. That's best done as cognitive behavioral therapy with a therapist. But if your loved one refuses a therapist, a family member, perhaps, could be asking those sorts of questions to help insight start to recover. So that's a very brief meander through the current evidence base. This is what we know about loss of insight and loss of sense of self. I could take a couple of questions or ideas at this point, Bob, if there's anything.
Yes. So one question, Doug, is you mentioned questions that could be asked when the person has a little bit of insight. Maybe you could give some examples of the kind of questions that might be useful.
That's a great point. So when there's just a chink of insight, what you saw the interviewer do with the John the Baptist role play was being too confrontational. He was trying to talk him out of being John the Baptist. That never works. So what we want to do is to ask questions of fact. You're telling me that there is a machine somewhere in the local area that is stealing your thoughts. That sounds like a frightening experience. Can you tell me a bit about it? Can you feel your thoughts going out of your mind? And what does that feel like? And you tell me there's a machine there. How do you know it's a machine? Can you hear it? And how big might the machine be? So it's asking these curious questions of fact about the delusion. So the person doesn't think they're being challenged. They don't feel they're being confronted. They feel you're interested and you want to know more. So that's the kind of questions I would ask when you get that chink of insight.
So that was the major question. I got the other one was a comment about the idea of maybe 50% of patients having a traumatic origin to their psychosis. That hasn't been embedded in our old NAMI family-to-family manuals. That's a bit new.
Yeah, it is. I mean, myself and David Kingdon reviewed all our clients with a schizophrenia diagnosis, and we found that lots of them, in fact, the majority, did have traumas in their background, and they often weren't disclosed. So you had to know quite a lot about a person to suspect there might be a trauma there. Now, things like bullying at school were quite powerful causes of subsequent paranoia. Various different types of abuse, emotional neglect, sexual assault. These things, unfortunately, often happen to our loved ones. And very often we don't suspect it. But we can very often find out if we do a timeline with them and we discover there's gaps in the timeline and they can't quite remember what was happening at that point in time, or there's a sudden change in behavior. So I saw somebody the other day who was telling me, yeah, at that bit in my childhood, I started cutting and my moods became unsteady. And I said, well, that's strange, isn't it? I wonder why that might have happened. And she said, I don't want to tell you why it's happened. I said, I'm presuming that something happened that shouldn't have happened. And she said, yes, I'm not talking about it just now, but I'll come back to it. So the timeline can help us find the traumas. It's very often an accumulation of traumas. So maybe somebody who has problems at school gets into a bad marriage and then they get domestic abuse. And as traumas accumulate, they eventually tip the person into a traumatic psychosis presentation. Now, when that presents to our services, they will often be given a schizophrenia diagnosis. And this goes back to my patient Charlotte, who demanded the diagnosis be changed and then recovered. I think that the DSM is opening up to the fact that there is a lot more trauma underlying schizophrenia. If it's there, we need to find it because it turns the person from being a poor outcome person to be someone who's got a much better outcome because there's lots of treatments for the trauma that is present in psychosis. I probably better stop on that because this is getting a long, long answer. Okay.
There's a few more questions. Do you want to go on now and we'll try to address those questions in the general question and answer, or do you want to take one more?
I'll take one more.
Okay, this was quite an important one for family members with quite a good relationship with their loved ones. what can they do to help the person move towards considering therapy? Are there any strategies or ways to communicate that are likely to be helpful?
Well, yeah, that's very often family members, the last person they will tell is a family member because they feel so ashamed about. So they're maybe more likely to disclose to the mental health services, maybe a psychiatric nurse. But if you have a suspicion that it's there, what you could do is show an inspirational a video like the TED Talk of Eleanor Longden. I spoke about this last time because Eleanor was traumatized and she was cutting and depressed and she was in a terribly pessimistic state. However, she reached out for therapy. She was given therapy. She fully recovered. And now she's a psychologist treating people with trauma. Her TED Talk is fantastic. So maybe letting a loved one see that TED Talk. You can maybe mention to them you've seen something which is really inspirational. Would they like to see it? Maybe we could send a link for Eleanor's TED Talk. She now works as part of our research team in the north of England. So
we'll put a link in the chat.
Yeah.
Thank you, Dr. Turkington.
Okay, let's move on, Bob, to the next bit, which is about medicine. So I've said that medicine can allow insight to recover. It directly allows that overheated bit of the right temporal lobe to start to cool down. As it cools down, your sense of self recovers and insight starts to recover. There's the dopamine blockers, which act on that pathway, and then there's the clozapine, which blocks everything apart from dopamine. And some people make fabulous recoveries with clozapine. So what will predict how they will do afterwards? Normally, as an inpatient, you will be started on a medicine and your insight will start to recover. Insight can recover very quickly in inpatient environments, and sometimes we've got to watch out for that. If you think about our John the Baptist presentation there, I mean, he never wanted medication, but if he did accept medication and all of a sudden realized, I'm not actually a very special spiritual person, I don't have this mission, I've got schizophrenia and I'm in a psychiatric ward. Wow, that is a big impact for somebody with a grandiose delusion. But insight in inpatient units can change quickly. So what are the big predictors of medicines being stopped? We've said we want people to stay on their medicines until the therapy work is done, because Kapoor says once the therapy work is done, they can slowly start to come off. Over a number of months, they can gradually reduce. Well, if there's a lot of family tension there and the family are divorced from the loved one and that support isn't there, that's a big predictor. The therapeutic alliance with the psychiatrist is massively important. It's one of the biggest factors we can control. So if you've got a doctor and you like them and you respect them, you will very often take the medicines they give you, even if you don't understand the medicine and even if it's got a side effect. So having a good prescriber is really important. One of the biggest factors. But the biggest one is poor insight again. So if that insight doesn't recover, those symptoms are just going to bounce back again because people are going to stop their medicine because they think they don't need it. And the paranoia, the voices start coming back through again and insight gets worse. If you're fueling your temporal lobes with amphetamine or crack cocaine, strong cannabis, you're constantly over alerting them, so the psychosis and the loss of insight is being maintained. So we've got to do something about substance abuse. And I think that is the last webinar in our series. And I'm optimistic we can do something about all of these things, that they've all give us opportunities of ways in to improve insight, but at different points in time. Let's have the next slide. So this just shows the research of antipsychotic medicine, which are keeping the temporal lobes blocked so they can't overheat, and people that are on a placebo. And as you can see, if you're on a placebo, relapse is almost inevitable. And it must be said, these are people who weren't getting any kind of therapy. They were just on a placebo tablet or the antipsychotic. And the antipsychotic was protective in maintaining insight and preventing relapse. If you can put the antipsychotic medicine along with the family therapy and the cognitive behavioral therapy, insight is going to start to come back. And that's what NICE recommends, that all three of these are evidence-based treatments and must be made available. Next one, please. So there are a number of practical things, and this is the kind of work that Don Veligan down in Texas did to support people's adherence, a variety of different supports, signs, remember to take the medication, keeping the medication somewhere where they're obvious, maybe beside a toothbrush, if the toothbrush is getting used, or beside the bedside table, using a checklist of the things we're trying to do during the day, appointments for medicines if it's a depot. So that's kind of the medicines issue. Medicines improve insight, but without something therapeutic happening, insight will probably relapse again when the medicine is stopped. I don't know if there's any questions about medicine, Bob, or maybe that's too quick for questions.
Some more general, well, there is one medicine specific question, which is about stopping and starting medicines. Does that affect the effectiveness of the medicines when they're stopped and then restarted multiple times, perhaps? Do we know?
Well, it seems to be some people can do that, and some people don't get better again. I had one young man who fully recovered on a certain medication. He stopped it, and we prescribed it again in the same dose, and he didn't get better. So some people are like that. I can think of other people who recovered in different medicines, stopped them, restarted them, and recovered again. So I don't think we really understand enough about that. But what most patients tend to do is to start their medicines. They use them intermittently. Though some people are good with their adherence, but a lot of people at start, they forget them one day, or maybe they lose the script and don't cash it in, and then they start again. So that kind of approach, the temporal lobe goes into shock when medicines are started like that. And if you're starting and putting cannabis or amphetamine on top of hypersensitive receptors, that's a massive relapse indicator. There are medications that have a longer half-life that are safer to start. I don't want to name any particular medicines, but some have longer half-lives. And of course, depots stay in your system. For some people, depots are quite a sensible choice. But depots are stigmatizing, and often they don't want them. We're going to have a full session on medication in, I think, a couple of weeks' time. Now, Don Veligan's work showed that these kind of reminders were actually effective. They improved insight and they improved medication adherence to a small degree. Could we have the next one? Now, this is 2 generations of the greats of cognitive behavioral therapists. Aaron Beck, who was in his 90s at this point. Me and Bob are the next generation, that right? And Helen Spencer here was my psychologist, and she is just about to train in clinical psychology. I'm going to tell you an amazing story about Helen Spencer under the enhanced insight bit of this talk. So Aaron Beck said, CBT improves insight. And that is one of the ways that it works. And he designed the Beck Insight Scale to measure insight. Let's have the next one. Now, this was a study which I designed, which is still fairly unique. And we called it the Insight Study, which was a very cunning name because it was all about insight. And what we said was, we're going to train psychiatric nurses to do 6 sessions of CBT. We're going to train the family member to deliver 3 sessions. So the family member was the co-therapist. And this is a great design. I mean, how good to be a family member who is a therapist and you're a part of the therapy. Obviously, the loved one might not agree to this, but if they do, it's a good way to work. And these were the components: engaging and normalizing, trying to make sense of the symptoms, improving coping, and families and loved ones can do that together. Starting to test out voices and delusions, improving medication concordance, work on self-esteem, and relapse prevention. So 6 sessions. Let's have the next one. And these were psychiatric nurses who applied to train in this. We trained them for 10 days. And they had to do the kind of role plays I was doing with John the Baptist personality there. They're doing a lot of these practice role plays. And they had an exam at the end. And then we gave them supervision. And the family members had supervision as well. Next slide. So did it work? Well, this is a very brief intervention. 6 sessions for the patient. 3 for the family member. You can see by the 3 stars above it there that insight was very significantly improved by the family member working with a nurse therapist. And overall symptoms, anxiety, depression, etc., anxiety voices, delusions, they were significantly improved. And clients were less depressed. What a result. I was delighted with this. And there is a hidden result in here when you cut it in terms of 60% of these clients had a family member, 40% didn't. The ones that had a family member had even better results. So having the family member working as a co-therapist was really important. Next one, please. So after 12 months, what had happened? The insight result was still there. Look at that negative symptom score. Wow. And this is what, if you get insight back, negative, you start to say, well, jinx, I'm going to get back into life a bit, you know. You start to get a bit of motivation to go and do some things. Negative symptoms start to lift. But of course, going out in the world again and tackling life, it is quite hard work as you start to rehabilitate. And so the depression benefits have been lost. But this is a pathway to negative symptom recovery with a very brief pulse of therapy. Next slide, please. What happened 2 years later? Well, we discovered there was a big difference in relapse. So 31% had relapsed within 2 years in the CBT group and 45% with treatment as usual. So that's pretty impressive for a brief pulse of therapy. Those people who did go into hospital, who'd had this co-therapist intervention, only spent 32 days in hospital, whereas the treatment as usual spent 48 days on an average. So they're spending less time in hospital. And time to relapse was different. So for the CBT group, it was 356 days, just about a year on average for that group, and 290 days. So they were quicker to relapse. Just a small pulse of therapy with a family member involved had a big impact. Now, we did the financial breakdown in this. We did all the costs of training the nurses, and this is cost effective because all of the expense comes in hospitalization days. So why are we not doing it? This is something that should be happening. Next one, please. Now, I think we should see some different ways of talking with the John the Baptist character. Do folk want to see the Baptist again? Not sure. Well, let's see him anyway. Let's see what happens. Because the therapist now is going to try talking to him in a different way. And let's see if there's any insight shift. Molly, could you put that second video on?
So we were talking about John the Baptist last time.
That's me.
That's you. Yeah, I remember. And I wonder whether we might talk about it a little differently today. I wonder if we might think about when you first realised that you were John the Baptist.
When I got my mission.
Yeah. That
is such an important time. I saw this cross in the clouds and I was just walking down Wall's End and this white cross, that is incredible. And I looked up at this billboard and there was pornography there.
Mm-hmm.
I don't know who it was, but she was hardly wearing any clothes. And my mind just, it all came together.
Yeah.
The cross, the billboard, the pornography.
What was that moment like for you when that first happened?
Oh, it was a complete revelation. All my anxiety fell to nothing. I knew then the meaning of my life.
So a very strong sense of meaning for you, Hannah.
Oh, it's so rich, the sense of meaning.
Really rich sense of meaning.
How can you doubt it?
It seems like it's really meaningful for you. How did you feel when you saw the cross there, when you made the connection and you had this really strong purpose in life?
Well, I had this weird feeling that something was going on and I was getting quite anxious, butterflies and stuff in my tummy.
Yeah.
Then I saw the cross and I thought, oh, that's really interesting. And then I saw the pornography and somehow the two just came together. Clear.
What was it like when you realised how clear your mission was? How did you feel emotionally? I felt
so full of energy. I mean, I probably had tons more energy than you would have.
So really energized.
Energized.
Yeah.
Full of it. I could go into any newsagent and just rip the pornography off the top shelf and say, there, that's what you're selling.
So a lot of energy, and it sounds like, am I right in thinking that quite powerful you felt?
Very powerful. Yeah. A lot of newsagents would say, okay, I don't want to sell it, but I do it for the money.
Yeah.
Well, that's no argument anymore, Tom.
Okay. I wonder if we could just think about what was going on in your life before you saw the cross. Just give me a context about what was happening in your life.
Oh, that was a strange time, really. I think I would say I was going through some trials and tribulations.
Yeah, such as?
Well, I was running this business as a mechanic and business went bust. They didn't pay their bills. and I lost the garage.
Mm.
So I was a bit kind of down in the dumps and nervy. And then my girlfriend went and left me because I wasn't paying the bills. So yeah, I was like, that was a terrible time.
It sounds horrendous.
But these are the tribulations that we go through to reach where we get to.
So that you see it as a trial kind of, or tribulation that you've gone through. At the time when it was all happening, though, before you realised you were John the Baptist, how did you feel about yourself?
Before I realised my mission, I was always a bit unsure about my role in life, really.
Yeah.
It's like I'd never really found my place.
Yeah.
I didn't mind working with the cars, but it wasn't enough.
Right. So you weren't quite sure of your role, and then some very difficult times came along. You described when you had your mission, how you suddenly felt energized and powerful. How did you feel beforehand?
Oh, I felt tired. And I felt sad.
Okay. Well, that seems understandable given the things that were going on in your life.
But it didn't last long. Because I saw the cross and the mission.
I wonder if you see any connection between the two things. So you feeling very low and lacking energy and not feeling important and feeling unsure, and then suddenly having a feeling very positive and very strong and very important in yourself. I wonder whether you can see that there's a connection between those two things.
Well, there's a thing called the testing time, when a soul is tested for a mission. Do you know about these things?
To some degree, yeah.
Because this is a common understanding.
Yeah.
In various religions that you go through these times.
So you feel that you were going through a trial in preparation for your role as John the Baptist?
Absolutely.
I wonder whether there's another explanation that maybe you haven't considered, and I wonder if I could put it to you and see what you think. That this idea came along to you because you were feeling so low and you've gone through such a difficult time in your life. And therefore, by having this idea that you were John the Baptist, it was a way for you to feel very powerful and energized. So actually, John the Baptist as an idea solved your problems in a way because it made you feel all the things that you wanted to feel, but weren't going on in your life at the time. What do you think about that as an idea?
I think it's a revolting idea. I mean, I can't believe I've been preaching to you this long about pornography and all its problems.
Yeah.
And you can come up with something like that.
You don't buy it as a possibility that could be the case.
We've got a mission to complete here.
Yeah. So you're still very sure that there's a mission to complete.
You're a doubting Thomas. That's what you are.
Well,
aren't you?
Well, I suppose I do have quite a lot of doubts, yeah, about lots of different ways of seeing things. And I wonder if you have any doubts about your idea that you're John the Baptist, and any doubts about whether I might be onto something here, that this came along at a time when you were so low that maybe that's why it came along at that time.
I was low at that time, and I don't mind if you want us to talk about that.
Yeah.
If that will help you to understand the mission.
Yeah.
I don't mind talking about that.
Okay. Well, I guess I'm wondering if there's if you feel that time in your life was the reason that this idea came along.
Well, I think I've already explained that was a trial time.
Yeah. Okay. So it's kind of a coincidence then. Is that what you're saying? That no, it was a trial and a preparation for. Is that right?
Got it.
Gotcha. Okay.
Yes.
Okay. All right. Well, all right. Well, it doesn't sound like that explanation is one that you were prepared to consider.
No.
Particularly, no. Okay. Well, I wonder whether for today we leave it there.
Okay.
Will that sound okay?
So the therapist does a bit better there. He finds the seed of truth at the heart of the delusion by asking how it all started. And there he found the emotions that this delusion was about. Now, he took it too far in the questions they asked, and the patient completely rejected his explanation. But it was a better way of talking than the confrontation of the previous one. So what we're trying to illustrate here is that there are different ways of talking to people with delusions. Some of them are more effective than others. Though it's actually the job of a therapist to work with the depression that is under this delusion. Is there any questions at this point, Bob?
So I'm not getting questions specific to the John the Baptist. Did you want to take a general question or move on?
Sure. Yeah, give us a general one.
Okay, this is an interesting one. It's a question about, are there any programs right now that are oriented to training providers, basically to help clients move towards accepting more family involvement?
Well, there's your own NAMI programs. There's,
Yes,
the LEAP intervention. There's Psychosis Reach up in Seattle, which I know that Maureen NAMI has had contact with. And Psychosis Reach is about training family members online as to how to deliver these kind of questioning approaches. Family therapy, some states have got it, an awful lot of states haven't. In the UK, we are least strong on family therapy, though everyone knows it absolutely works. And all the evidence points to that. My insight study was never implemented big scale, which is a shame, because having a therapist and a family member co-therapist would have been fantastic. So I think a Psychosis Reach up in Seattle, and maybe the link could be put out for that. And if anyone want to sign up, they could sign up for those live events if you want to learn about these types of approaches.
Did you want to take one more question, Doug, or move on?
Yeah, sure. That's another one.
So the other one is some general comments in the chat that basically signal it's so difficult to engage with providers. Providers so often we have a United States HIPAA law that is a privacy law. They often use HIPAA as a screen to not communicate with family members. And I don't know if you have thoughts about this. I certainly have thoughts about the stigmatizing family members.
I think the confidentiality law is being misused. I think it is at heart a reasonable idea, but if it is being used as a screen to prevent access and to reduce the stress within psychiatric services, then it's a very, very bad thing. Because we say recovery begins at home, and it really does. You need the family members working with you, with the medication, with the therapy. And if that's not happening, we can see why so many people get stuck, can't we? And what was the second bit of the question there, Bob?
It was mainly the difficulty communicating with providers, getting acknowledged, getting information to providers.
I think, providers, they certainly listen to lawyers' letters, but what a shame if you've got to write in and say, my loved one has never had a trial of clozapine, I've not had CBT, these are evidence-based treatments, where's our treatment? Provide it or I'm going to sue you. It's a real shame if it's got to go to that.
Yes.
But that has happened in the UK. But I would normally approach psychiatrists with information that they're interested in. So like the kind of stuff I'm talking about with Insula, we've written a paper about that, which shows how CBT works in terms of reducing cortical overactivity and how it complements medicine. Now, a lot of psychiatrists don't know this work. So I would take bits of literature to them about the biological and medical model and show them how it fits together. because I don't think this message is quite out there enough yet. So that's the kind of thing I would be doing, I think.
So Doug, maybe we can work to put up some of these papers on the website. It might take a bit of time, but with an idea of a package of papers that would particularly speak to psychiatrists.
I think that would be really useful.
Yeah.
Yeah, absolutely.
Thank you.
Okay, give us the next slide. So, yeah, you all know these things. I don't need to mention them. That this is what you see day in, day out. Choosing not to listen, stuck in a world of psychosis and anxiety and stigma, unable to see your point of view, not quite reading your cues, not listening. And it's very difficult, isn't it? That's how the support of NAMI and this program is fantastic for families. And the Psychosis Reach program has a family ambassador service whereby you get linked to people that have been in that program, and they try and help you with your specific problems with your loved one. Let's have the next slide. So I mentioned right at the start, there's lots of reasons why they don't want help. Lack of insight, anosognosia, that more extreme variant of lack of insight. Stigma is so powerful. And that's why normalizing approaches is so useful. When we first started doing it, normalizing was what patients liked the most. When we explained that 1 person in 7 had an episode of voice hearing. And it usually got better, and there was usually a cause. What was so useful. People that seal over want to forget it ever happened. And of course, that is something that isn't good because they stop the medicine too quick and then run to relapse. Sometimes there's voices telling them not to talk to anybody else. And that's one that can need a bit of work to break through that. In particular, the Intervoice website is quite useful to explore the kind of voices that other people hear and the kind of things they say to them. So Intervoice is good. Maybe they've got a delusion that you're part of the persecution, or maybe with this loss of boundary, they're not quite sure who you are. You're like, I know you're saying you're my dad, but I'm not completely sure who you are. That's what this loss of sense of self and loss of boundary does to you. Negative symptoms, thought disorder, all possibilities. Let's have the next slide. But there's so much more. There's interpersonal issues, emotions get in the way. I mean, so many of our loved ones are self-treating with substances and alcohol. And I mean, God, you've got to be honest, life is so difficult for them that I kind of understand that. I understand why you'd be using cannabis if it's given you a bit of respite from all this anxiety. But it's ineffective. It doesn't work. We'll come to that in the last webinar, why it doesn't work. But they're often using substances which interfere with their recovery opportunity. Developmental reasons, adolescence is a tougher time now than it's ever been. Lots of people just don't believe at all in medicine, and they would avoid it at all costs. But our action study showed that people that avoid medicine will very often take therapy if it's offered. So we said people should be offered a choice. If you refuse the medicine, then let's have a course of cognitive behavioral therapy or family therapy. And wherever you have early intervention and psychosis services, those choices should be available. I'm presuming you've got that in Marine County, Bob. Early intervention services?
Yes, we do. When I last looked, it's quite a small program. They haven't treated many people.
So it's just starting off, But
It's
early
probably 2
intervention
years.
services are really important for plugging these key treatments in. And again, they're cost effective. So there's no reason not to do them. Some people believe in cultural remedies, certain types of tea, certain things like that. And sometimes we've got to pilot them to see if a person believes in them, as long as they're not going to make them worse. We could try it for a bit and measure their symptoms and see what happens. So it's this idea we've always got to go to where the person is in terms of lack of insight to get some kind of collaboration, some kind of joint approach, and we can build on that. So the problem is when we can't get access to that collaboration, we can't go anywhere. So I'm always looking at ways to get collaboration. Let's move on to the next one. Sometimes things are broken down. The person won't talk to you at all. What do we do in that situation? Well, we mentioned befriending again, and even when relationships have broken down, it is possible to start again, to go back to square one and try and be a friend to that son or that daughter. Go back to the start and say, I know we weren't communicating well, and apologies about that, but can we try again? Start off with a card or a phone call and just start building up. If they're in another state or another country, that also applies. But there's always the chance of using Zoom and other mediums to gradually build the rapport and the collaboration. Let's have the next one. We want to find out exactly what it is they want help with. We want to describe it. Like with the Baptist case, we want to deal with risk first because risk affects everything else, and work out why they're refusing help. That's the next one. So we can ask questions if there. I've had a number of young people come in to see me, and they're sitting there with the hoodie down. I can hardly even see their face. The head's bowed over, and they're saying nothing. And somehow we need to reach the person through that. I can see that you've managed to get here today, and that well done for that. But it must be difficult not really knowing what to say. Would you like me to ask a few questions or tell you something about me and the services we have here? We've got to get them talking about something. Are you trying to think out something you might want to say? Or is there something about me, is something that makes it difficult? Is there anything you would feel able to talk about? Say it might just be the soccer or the sports, or I don't care. We'll start anywhere. Getting insight to improve needs a starting point. It could be anything. Then you can work with images. If a person says they're swimming against the tide, you can ask what that feels like and how hard they've got to swim and what stroke they're doing. And exploring the image, it can give us access to their inner life. Images are a good way to develop collaboration. Let's move on to the next one. Now, enhanced insight beyond psychosis. So insight is a truly strange phenomenon. Sometimes people can be very psychotic and have enhanced insight, or their insight grows and they then moved into a position where they seem to have more insight than we have. So I had one man that I visited with that psychologist who you saw earlier, because she was training, and I was trying to assess his psychosis and he wouldn't talk to me. And I saw that he had a book on his shelf, which was Criminals of England. I thought, oh, that's a bit unusual. I said, can I have a look at your book? And he said, yes. So I looked at Criminals of England. I said, oh, yeah, I've seen a film about the Cray twins. They were famous old criminals. Oh, he said, yeah, I knew them. I knew the Crays. We're in. We're in. He's interested in the craze. I know something about it. It's nothing to do with psychosis. He says, I've got a letter from one of the craze. I said, will you let me see it? He said, yes. It was true. It looked like a real letter, one of the Cray twins. I said, that'll be worth a fortune if you were to sell that. He says to me at the end of it all, he says, you know, you've been really good to me today. He said, you've been civil. And I respect that. He said, I'm going to give you some knowledge. You think time is linear. You think it goes in a line from the past to the future. Well, it's not. Time is a coiled spring, and the spring moves, and there are times when the present and the past are happening at the same time, and there are times when the present and the future are happening at the same time. And I'm going to prove it to you. I'm going to give you 3 tips for 3 horse races which are running this weekend. Put as much money as you've got in the first horse, take the winnings, put it in the second, and the winnings onto the third. He wrote down the names and the meeting which it was happening at. So I said to Helen, who was there, I said, this is a delusional memory. And Helen said, I don't think it is. He seemed to say these races had already happened. He had seen the winners. He wouldn't do that unless he had some insight. I said, well, look, we can't be wasting our money on this. This is a delusional memory. So she said, we're going to go to the betting shop and put £50 in that first horse. Psychiatry is interesting in the UK. So we went to the betting shop, bet the first horse, it wins. 12-1. Helen wins £600. She says, I'm going to put my winnings on the second horse. I said, no, this is madness. This is a fluke. She said to me, he told you these races have already been run and he'd seen the results. I said, well, we're not putting money on. Second horse wins, 20-1. The third horse was called Go Go Green. It was 80-1. Nobody was betting on Go Go Green. Helen phones me up. Can I put some money on Go Go Green? I said, no, this is a donkey. It won't even reach the finishing line. So the race starts. Go Go Green's at the back. It starts to accelerate through the field. It wins the race by a head. Every single prediction was completely true, and nobody would have bet on Go Go Green. So Helen phoned me up and she said to me, you're an idiot. I had to say, yeah, I could see what you mean by that. But maybe we've learned something about time here. That this is fascinating what we learned. And I mean, that was about 20 years ago. And if you look at modern theory about time, what he is saying is much nearer to what is actually believed than the linear version of time. So, pretty fascinating. He seemed to have enhanced insight. If you think about Albert Einstein, his brain was just different, and he thought in a different way. His son, one of his sons, spent his life in an asylum with schizophrenia. So it's very, very close between enhanced insight and genius and psychosis. This second one was about a monk that I met in China, and she meditated for 7 hours each day doing mindfulness meditation. And she did it for 14 days at a time. And she said that by day 10, she could see previous lives that she had lived in front of her eyes. She could watch them happening. So she seemed to be able to believe she could see the past. But she told me that there were times she had to stop because she believed she was becoming psychotic. So she would have to come out of the meditation and have a breather before going back in again, because she felt that psychosis was that near. So she was massively insightful around the psychosis meditation interface. The next two are about a Vincent van Gogh, and he, of course, fabulous impressionist painter. He had temporal lobe epilepsy, which was untreatable at that time. And his temporal lobe epilepsy caused schizoaffective psychosis. So he had manic psychotic swings and depressive psychotic swings. And of course, in one of the depressive ones, he cut his ear quite famously. And he said these kind of things: I've put my heart and soul into my work, and I've lost my mind in the process. Though I'm often in the depths of misery, there is still calmness, pure harmony and music inside me. I see paintings in the poorest cottages, in the dirtiest corners, and my mind is driven towards these things with an irresistible momentum. So he's reached enhanced insight, one of the greatest painters ever. He has a psychosis. John Nash is the last one of Beautiful Mind fame. He said, I wouldn't have had any good scientific ideas if I'd been thinking normally. And this is an echo of Einstein, the way his thinking worked. Things just came into his mind. He didn't know where they came from. Amazing equations, great jumps forward for humankind just came into Einstein's mind. Enhanced insight beyond psychosis. Let's go on to the next one. So, nearing the end of this bit of the webinar, find it if you can, why they won't ask for help or won't talk to you. Work out if there is any risk, and if need be, once you've got some collaboration, try and do some with the risk first. Use the appropriate style of discussion. We saw the questioning of the John the Baptist that wasn't quite ideal for him. It would have been slightly different to be optimal. Try and get a goal that you can both work towards. Think about the fluctuating insight on my slide earlier. There are days when it will be easier and you might be able to make some progress. Try and reduce stigma, and normalizing is good for that. Use curious questions. Hope we've demonstrated that. And explain about the full range of treatments and work with the one that they're agreeable to work with and try and build from there. Do you want to move on to the questioning side now, Bob? Maybe stick up the next slide.
Doug, did you want to take a brief break before we go for questions? We've got about 15 more minutes.
I think we'll just go straight for any questions that we may.
So if people can submit any specific questions about insight and in the chat.
If there are no questions, Bob, you could ask a question, or Molly could ask a question, or you could interview the John the Baptist live.
Oh.
I'll come on screen right now. I know what he's like now.
Well, let me ask some more questions. I'm very interested in, and I know we're going to maybe cover this at other webinars, but what would be some examples of kind of curious questioning that isn't threatening, that might open up a discussion? Do you want to do this as a role play, Doug, or just talk about it?
Well, I can talk about it and then we can do a role play. So the John the Baptist type character, curious questions that he might be interested in might be to say, wow, you're telling me you're the second coming? I didn't know that a second Baptist was prophesied. So is there anything in the New Testament or the Old Testament that talks about a second Baptist? So I'm not challenging him. I'm just saying it's fascinating. I would like to know if there's one of the old prophets have said that that's going to happen. Or could we think about the first Baptist? What did he do exactly? Because he was baptizing in water, wasn't he? And I think Christ appeared at around about the same time. I'm not completely sure of my history in that. So it looks like you're using fire rather than water. And I wondered why you were using fire rather than water. Is there a reason for that? Just try and explore more about it. Going pre-psychotic, certainly I would ask him a lot more about the problems he had with the garage and his partner leaving him, really important issues, particularly in relation to the pornography issue, that there's something in this delusion about his previous relationships. So I would be exploring them. I remember one day I said to him, you know, my car's not working very well. Could you come out and have a look at it? So that was a kind of a very curious question. I was saying, like, you're an expert mechanic. I'm not denying the role that you currently believe you have, but my car's not working. Could you have a look at it? And he had a look and he found an electrical fault, and I was very, very grateful to him. It just took him out of the stuckness of the delusion. Just like my patient with the enhanced insight, when he started talking about his subject, which was these gangsters, oh, he totally brightened up. That was a crucial starting point, is to find that subject that will make them brighten up. And everybody has something, don't they?
So, Doug, there's a couple of questions here that are coming in. So one is about, this is a family member who's doesn't really have insight, and they're kind of sharing their delusions openly with a number of people, like the clerk at the grocery store. How should a family member deal with this kind of situation?
In some ways, that's an opportunity. And in some ways, it's slightly risky because we don't know the nature of the delusion. So it would be good to know if the delusion is frightening the people at the grocery store, or if it's something we could begin to talk about. These curious questions. Then how did this all start? What was happening in your life then? Because very often people that are very deluded, like the Baptist case, once you get them talking about pre-psychotic, their mood changes and they stop talking about the delusion. But this is therapy. This isn't really something a family member can get too involved in. But if you see the seed of truth in the delusion, and normally families know what it is, they normally know, then we've got to be reaching out to getting that therapy intervention. And of course, you've shown, Bob, that this can be done remotely for many people. So maybe a remote Zoom therapy might be less threatening for someone with a delusion like that, and might start to make a bit of progress. I'd like to know the nature of the delusion. I think that's quite important about that question.
And is there something you could say to the family member that would sort of help them make better decisions about who they're talking to, for example?
Well, yeah, that's a good point, because some people are going to be interested in non-judgmental and will help them explore that issue. Other people will tell stories about them, stigmatize them, be critical. So yeah, I think we do need to pick and choose who we're talking about our delusions to. I think you get into lots of trouble.
Yes.
And when the word gets out there that you have a particular belief about aliens abducting people in your street or something like that. And if you're putting that out there all the time. So yeah, it depends what it is, but it would be good to contain it And a lot of people can contain it, particularly if they have a therapist or a family member. And you say to them, you can talk to me about this, but why don't we just keep it between ourselves? I would think that's a good point.
Yes. Yeah. There's another question about, it's really about providers. Many providers simply refuse to work with people that don't have insight. And this is really frustrating for family members. Is there some strategy family members can use to kind of address this problem with providers?
Well, it's the commonest symptom. I think early intervention and psychosis teams will never exclude somebody for lack of insight. We view it as our job to engage people without insight. Now, obviously, the family can't be left trying to engage the person.
Yes.
That's a job for a mental health professional team who start to build up that rapport and then support the family. Then you're part of a team that's working together. So I think with your fledgling early intervention psychosis team, that will start to come on stream. If you look at acute inpatient psychiatry, what they normally do is plug in the medication, get things safe, discharge. So if the medication is there, you hopefully have got a bit of insight improvement. We then need the community team to come out and visit that person and deliver the treatments that allow insight to improve. Cognitive behavioral therapy, family therapy, psychoeducation, the third wave of cognitive behavioral therapy. All of these interventions can be useful, but cognitive behavioral therapy is the one that is most evidence for insight improvement.
Okay. And just one other thought about approaching providers. My sense is that sometimes we can get some leverage by just asking, are there any problems that you'd like help with? Maybe you don't agree, right, that you've got schizophrenia or psychosis, or that you have a problem with delusions, but how could I help you with other problems you're experiencing? Kind of as a way of getting started.
That we've got to get started. And me speaking to that chap about the gangsters of old England,
Yes,
we were in, that was great, and we built from there. It sounds like a silly starting point, but it worked. I can think of people that have started to speak to them about bird watching because they were in the bird watching society before their psychosis. And they started watching the birds outside the window, and I would ask them what kind of birds there'd been there. That was the starting point. And we then were able to build from that into going out into the garden to watch the birds and trying to feed them. So it's starting with something, isn't it? And then building up. But that is what our early intervention psychosis teams are meant to be doing when they visit people at home. And that service will need to be much better provided in terms of personnel. So NAMI, Marine County, could be lobbying for that early intervention team and the community teams to be getting CBT psychosis training.
Yes, Doug, as you know, we've provided training in the past through you to county providers. Yeah.
That's very true.
Yeah.
I'm getting a lot of contact from across North America of people saying, we want to start up CBT for psychosis services. We just don't know how to do it. Can you send us materials, training webinars, videos, so that we know what to do? So I think that there is more of a will now to do this than maybe there was in years gone by. And hopefully the kind of webinars we're doing here will maybe be the kind of thing that these services can click on and watch things like this.
Excuse me, I'm Ellie Baldrick, and I'm afraid I don't know how to use chat, so I wondered if I could just ask my question, please.
Yes,
if that's okay. And I was a licensed psychiatric social worker for over 30 years, and I worked for the county of Marin as well as up in Seattle. Dr. Turkington, I think you're terrific. My worry is how to implement the wonderful ideas you have when the average clinician here in Marin County working with psychotic adults has over 40 clients on their caseload. Our doctors may have a couple hundred clients on their caseload. And I think that's one of the reasons it's so hard to get information, get a hold of providers. I mean, I agree with all the HIPAA concerns and whatnot, but the sheer numbers is what is a real concern to me of how do we implement these strategies in the face of that kind of caseload size.
Absolutely. I think part of the problem looking on from the UK is the funding of it. So when people are funded through insurance, psychiatrists are only allowed, I think, 15 minutes. That's all they're allowed. And they've got to go through a certain number or they don't get paid. So there's something about funding. The funding in the UK and Scandinavia is different. It's more orientated towards results in terms of patient benefit. So there's lots of measures for hitting targets, hitting people early, getting people out of hospital, getting people into recovery. So we're paid differently. And that's not going to change quickly, but there's also a need for a political change, isn't there? We need someone at the top to say, this is an evidence-based treatment. So the chief of the APA said, we're in danger of becoming a bio model of mental disorder rather than biopsychosocial. We need to deliver social treatments, such as a community accommodation with therapeutic options in it. We need to develop family therapies, individual psychological treatments. We know that they work. People need to get them. And all the states are different. And as far as I can see, some of the richest states have some of the lowest levels of provision. Yeah. So as a Scot looking on, I can't quite understand how it all works, but these seem to be the key issues. So I think it'll change differently in different states, depending on state motivation.
Yeah, I just want to make a comment. I think when we look at implementation of these programs, it depends upon the leadership. And it's really going to be about advocacy with the leadership. Each county in California has different leadership. Some counties have been very committed to CBT and training, like Los Angeles County and others, and some not so much. So a lot of this is advocacy with the leadership in Marin.
Yeah.
Where there really isn't a leadership commitment to implement these programs.
We need champions in politics, in NAMI.
Lots of letters.
Local services for advocacy. But we're by no means perfect. You can go to bits of the north of England where you won't see a cognitive therapist and you'll just have a psychiatrist dishing out stacks of medication, massive polypharmacy. So across the UK, it's a postcode lottery, you know. I mean, if you're in one place, you're in a genius service. It might be 10 miles down the road, you're getting next to nothing. Maybe that's just the way of it. Maybe we need local champions and politicians to keep pushing. I still think we're swimming with the tide. You know, I've thought this for 30 years because 30 years ago, when we started out in this path, that there was really nothing. There was only medicine. There was some social skills training. There was some groups, but there wasn't much else for schizophrenia, psychosis, and bipolar. So I think things have really improved, and I think they're still going in the right direction. But I'm an optimist.
We probably have to start closing up here. Molly, if you could put on the last slide. So I really want to thank Dr. Turkington for his amazing work with NAMI Marin. I'm extremely grateful. I want to thank the families And I want to thank our donors and supporters of this program. There's a lot more we can do. We're just getting started. There's a number of questions that came up in the chat about resources and materials that we will post on the website. For example, there was a question about the Hearing Voices Network and InterVoice. We'll post those links and resources. Give us a bit of time, give Molly a bit of time to do that. If you've enjoyed the presentation, I hope you'll consider donating to NAMA. You can click on the link on your slide in your packet. And it's very important that you give us feedback on the survey again. Last time we got about 70% of our participants responding on the survey. So thank you so much. The surveys are massively important. It'll just take a minute or two. Again, you can click on the survey link. Yeah, right on the screen. There you go. Okay. And you're going to copy it into the paste. It looks like, is that right, Molly? Molly's going to copy it into the chat as well. Fantastic. So now it's in the chat. You can click on it and go right to the website with the survey. So again, we're very grateful to be working with Dr. Turkington, a world-class researcher, clinician, cognitive therapist. We're so lucky, and I want to thank you. And again, thank all the families for participating today. Okay. Thank you so much.
It's been great to see you all.
Yes.
See you next time.
We're going to be closing
Thank
up
you.
here. Okay.
Bye-bye for now.
Bye, everybody.
Bye. Thank you.